let me kick off this meeting, which will be the final 2023 meeting of the Ostrom workshop on cyber public health that CyberGreen and the Ostrom workshop are co-hosting. Doing this on Thursday just happens to land us on Thanksgiving and Christmas. So we'll be kicking off again in the new year. And this session, we've got Irving Lachow, who I think I've known you for 20 plus years in various cybersecurity roles, innovating, driving change. And somehow we had not really ended up talking about evidence-based medicine. So I am really excited to hear from you and hear what you have to say. And do you want to just take it away?
Yeah, thanks, Adam. That would be great. Love to dive in. Let me see if I can share my screen. So can you guys see my?
Yep, that's working.
Okay, great. Let me move this thing. There we go. There. Oops. Okay. So as Adam said, this is going to be a discussion around evidence-based medicine, which be honest, I don't know that much about. My wife, who works at MITRE, she's an economist, has done a lot of work, and I've heard her talk about evidence medicine over the years. And so, in thinking about cyber public health and talking to Adam and Yuri about various topics, I thought, well, why not dig into that and see if there's a there. And so my intent is to spark some discussion around this topic. So I am certainly not an expert, and this is early stage thinking, but again, hope to dive into it with you guys and see where this goes. So really looking forward to just seeing where we take the conversation. So pretty simple agenda. Just start off talking about, well, what is evidence-based medicine? What are some of the benefits of its application? What are some of the challenges? And then what are some of the findings in terms of how it might relate to cyber public health? And then hopefully we'll have lots and lots of time to talk about it. So evidence-based medicine is this concept of combining, not surprisingly, evidence based on research, and we'll talk about what that means in a minute. So taking research, combining it with clinical experience and the preferences and values of the patient to make recommendations on treatment. So there's sort of these three components, right? Evidence, which is research-based, clinical experience, and preferences of the patient. And again, we're going to get into all that as we talk about this, but those are sort of the three key components of this. And because this evidence question is such an important one, as you'll see as we get into this, I wanted to just take a moment to talk about, I use the term pedigrees, but sort of, different categories, if you will, or levels of quality when it comes to evidence. And this is something I've taken from one of the papers. By the way, I have references in the back. I didn't want to clutter the slides with footnotes, so I apologize for that. But I've got the references in case you want to know where this came from. And these are sort of levels of quality of evidence and research, right? So at the top you have meta-analyses of well-conducted randomized control trials, right? That's like the gold standard. Randomized control trials are sort of the gold standard. And then a meta-analysis of those is even better in theory. If you have good inputs, right, that are feeding that meta-analysis, then you get hopefully these very broad scale kinds of findings, which would be, I think, directly relevant for cyber public health, right? And then as you move down this pyramid, you go from the meta-analyses to, single well-conducted randomized control trials. Then you get to well-executed non-randomized controlled trials, where there's a risk of bias, and then you can keep moving down to, cohort studies, case control studies, non-experimental studies, like you see that a lot of the level 3 stuff, for those of you, I don't know if those of you who follow things like exercise, there's a lot of findings in the exercise community about these kinds of things, about like certain exercises that are supposed to be good for you, or some of the nutritional studies actually tend to fall into that category. And then at the bottom, you just have expert opinion. So this is just something for us to keep in mind as we walk through what we mean by evidence. So why is evidence-based medicine such a big deal? And it is a big deal. The concept's been around for decades. As I mentioned in a slide later, if you do a Google search on the topic, you get 2 billion hits, right? There's a lot of work in this area. It's a lot of organizations actually use it to allocate resources, and insurance companies use it to approve treatments, et cetera. So it's a really big deal. And one of the reasons for it is if it's applied well, like in theory, it's going to do a lot of good, right? Because one of the things it does, obviously, is it standardizes treatments, and it standardizes them on evidence. So everything done well, this can really help a practitioner. And, one of the challenges for practitioners is it's impossible to keep up on research, right? So I found the statistic. I don't know if the number's right or wrong, but even if it's off by, whatever factor of 2 or 3, the point is, a physician would need to read whatever the number is. Let's just say 20 articles a day to keep up on the latest research findings. And of course, that number is increasing, and probably increasing exponentially, right? Given the rate of information that's floating around the planet. And I would say the same thing at some level might be true with cyber. That's something we can discuss. But the point is, it's very hard for individuals to sort of figure out what's the best practice, right? So if there's a standard of care based on hopefully good quality evidence, that makes it much easier for these folks to apply these best practices. And then again, this can also standardize care, which can be very helpful because practitioners may have very different personal experiences depending on where they practice, the type of patients they see, et cetera, and there can be these significant discrepancies between these practices. And so again, hopefully using this, you can apply best practices across a wide range of scenarios. Then of course you can look at the literature that I'm sure you're all familiar with in terms of biases and heuristics. And so if practitioners don't have something to sort of check themselves against, they can fall subject to these biases and heuristics. And there's a lot of research on that. That if you follow, the health literature, I'm sure you'll see that there's, in terms of treatments that doctors use, they often prescribe treatments that are, in some cases, have been demonstrated clearly to not be effective, right? But they're just used to doing it, or 20 years ago, they were taught that was the right thing to do, et cetera, right? And so they kind of follow that approach. And then a final benefit is you get transparency and accountability. So it's very clear why a given course of action is being pursued. And that can be very helpful, not just with explaining to a patient why a particular treatment has been followed, but at a higher level, you can start to sort of look at broader treatment plans, and maybe even, in the case of organizations like, hospital or a medical clinic, you can start to justify equipment that might be needed, or, tests that need to be run, et cetera. And that can be helpful, all going all the way up to CXOs, boards, insurers, et cetera, right? Is there's this ability to explain rationale for a particular choice, or for decisions that might need to be made. So in theory, this all sounds like really good, which is why evidence-based medicine is such a big deal. Let's see if I can actually get it to go to my next slide. What are the challenges with doing this? Well, the first challenge that we'll talk about is the evidence piece. So going back to that list of the rankings, right, of sort of good evidence. Well, there are all kinds of things that can creep into that, and many of these may be relevant, I think, for thinking about cyber public health. And by the way, a lot of these show up in spades when you think about epidemiology, and that's again something that we can talk about is some of the similarities and the challenges between epidemiology and this kind of evidence-based medicine. So one is statistical significance, and what are the thresholds that are used in these studies? They can vary quite a bit. And as you all know, depending on where you choose your, your p-value, whatever, you may get very different findings, right? In terms of what is a best practice, what isn't a best practice, or what is statistically significant and what isn't. And so you get into all kinds of questions about best practices around, your p-values and whatnot. Another challenge you get into is that in a lot of these studies, especially if you're trying to look for things that are useful for, the broadest possible population, is you may miss things that are, either weak signals or something that's found in a long tail. And that's something we're going to talk about. That's kind of a weakness of this, right? Which is there, especially when it comes to things like patient health. There may be things that are in those tails that are really, really important. The other thing is when it comes to innovation, a lot of times the most innovative, like to sort of discover new things, you often have to look in the weak signals and in the tails, because that's where something new and interesting is happening, right? It's not going to be in the 2 sigma part of the normal distribution. And that may be lost in this kind of approach and in this kind of research. And then you get issues around, the heterogeneity of the patient populations in these different studies, especially if you're doing meta-analyses, but even in some of the other studies. And this is a classic problem when one is doing studies. And, the canonical example is the number of psychology studies that are done using college students because they're readily available to academics, right? And you get findings that may not necessarily apply to, folks in different populations, different age groups, et cetera, et cetera. Same thing can be true with a lot of these health studies. And then you get into different biases, right? So there are biases in publication, and those of you who've spent a career in academia may be aware of this, right? It can be hard to get articles published, especially if those articles buck the currently accepted wisdom. And there's a lot of examples of this, right? So it can be hard to get innovative thinking or important thinking out there if people don't think it's true, or if it's just, again, sort of bucking the system, if you will. And then finally, you can get biases that show up in the data itself. And then there are just some health problems where there isn't very much data. And of course, that is a huge issue we have in cyber, which is something we should talk about is, this evidence-based thing sounds great, but you have to gather evidence. And as we all know, it's the issue of metrics in cyber, and doing, trying to do a controlled study in a cyber environment is extremely challenging, something we can talk about. So these kinds of issues are certainly relevant for that. And then you get sort of challenges just in the implementation. And again, a lot of these things I think are going to be relevant in the cyber realm. So one, of course, is that clinicians and practitioners often don't understand statistics, and they often can't make judgments about the quality of studies they may be relying on. So they may be relying on a study that's actually a faulty study or that wasn't well done, and they have no idea. And so that makes it hard sometimes to judge the validity of guidelines, especially if the guidelines that might be based on, as opposed to a meta-analysis, maybe something a little more cutting edge, might be based on a small number of studies. And if those studies are flawed, the practitioner may not understand that. And then you get into these judgment questions, and that's going to be another theme here of trying to understand when to use these guidelines and when not to, right? Because again, these guidelines are probably going to apply to, a generally be useful best practices. Doesn't mean they're going to be best in all cases. And so what can happen, and I think, it does happen, is that a treatment that may be inferior on average, and that's shown in the data, may actually be exactly the right thing to do in certain cases, right? But the way these findings are often presented is those things just kind of get thrown out with the baby gets thrown out with the bathwater, right? So you compare treatments, you say, well, on average, this treatment's better, so it becomes a standard of care. And there isn't necessarily this sort of caveat that, hey, maybe in these other circumstances, you should use this other treatment. That might get sort of lost in the noise. And that subtlety may not be present in some of these guidelines. And then the other issue you get into is sort of an organizational dynamics one, which is that these guidelines can actually start to limit what clinicians can do. And this is where incentives come in, right? Because if a hospital or an insurance company says, well, we're going to base reimbursements or guidelines on these standards of care, in a case where a physician may actually realize that they need to follow a different course or a different standard of care, they may not be supported when they want to do that, right? And that there may not be, the patient may not be able to get reimbursed, or the physician may run into problems if they're not actually following these guidelines. So I wanted to take a moment just to step back and just put up the definition of the cyber public health effort and the evidence-based medicine one, just to note that there are similarities, and I think there's a lot of overlap. And again, hopefully we'll get into that in the discussion. And I think there's this interesting, perhaps, complementarity where cyber public health, a lot of that focuses on the sort of population level kind of thinking and epidemiology, where you're really looking at systemically and maybe even looking over time. And at the end of the day, a lot of evidence-based medicine is about decisions for specific patients. Now, while that's true, the way evidence-based medicine is implemented is it actually is often implemented at a more population level, as I was just saying, right? So a given hospital or a given set of insurers may be driving those evidence-based medicine decisions to affect populations of patients, not individual patients. But the actual sort of practice of evidence-based medicine is supposed to happen at the patient level. And so, perhaps, and I'll mention this, in a coming slide, that brings up the question of, is evidence-based medicine a model for thinking about decisions that are made at the enterprise level when it comes to cyber? So is that the equivalent as like a CISO making a decision about an enterprise? Is that the equivalent of a practitioner thinking at a patient level? So something we can talk about. So these are just some of the trade-offs that I think come with trying to think about evidence-based medicine, and I think things that maybe we could think about and talk about, right? Which is that the first is this question of how do you gather evidence? And in particular, if you want to apply this concept to cyber, how do we gather that evidence? How do you run experiments? What's the equivalent of randomized control trials, or even even non-randomized control trial, right? Between enterprises or whatever. It's just, how do we run these experiments? How do we gather this data? The second is that the benefit and value of this at the end of the day comes down to, if you pardon, the economics term, one's utility function. What do you care about most, right? Is it better to have a better, hopefully improved performance on average, but know that you're suboptimizing at the tails, right? So there are going to be individuals who may not get the care they need, but on the whole, you're doing better. Or is it better to sort of let clinicians have more freedom and potentially err more in general, but have more freedom to actually better treat the people on the tails of the distribution? So it's essentially, which risk do you care about most, and which risk do you want to avoid the most? And that's a judgment call for executives, decision makers, et cetera. And I thought that might be something interesting for us to discuss, is when we think about cyber, and this gets to questions around things like NIST guidelines and best practices in the cyber community, as well as which risks are we trying to sort of address more, right?
Could I jump in for just a second?
Oh, absolutely.
You said which risk we're trying to address more, and I don't have a clear A-B in my head. Could you just clarify the A versus the B risks that we care about more there?
Yeah. So if what you're trying to do is sort of focus on improving things on average, then you could sort of blindly apply these best practices, given all the caveats that I provided earlier, right? And what's going to happen with that is, in theory, should do better than someone who is just using their intuition or just applying their own personal experience, right? So in theory, if they're relying on evidence, then they should do better on average. However, they are likely, if they apply that, they're going to not do as well applying those best practices to the people where that average doesn't apply to them, right? The people who fall outside of the generally recommended best practice. So you're going to be sub-optimizing there, but hopefully doing better with an average population. The flip side is to essentially not do that and let people have a lot more freedom to sort of rely on their personal experience, have a lot more freedom to to use whatever practice they feel is best, the risk of that is there's the potential to introduce more of the bias, more of the risks that I talked about in terms of personal bias or, not applying things that in general are viewed to be good, for the population as a whole. So do you care more about, doing better on average, whatever that means? And that's something we could talk about. What does that mean? Does that mean you're doing better 60% of the time, 90% of the time, right? And that's where I think the quality of the evidence may come in, versus, it may be really, really important to be able to tailor what you're doing and not rely on, the sort of generally accepted best practice, but actually have much more freedom to sort of focus on specific subpopulations. So I think there's sort of a trade-off there. Like, one might say, well, we should just do better on average all the time. And somebody else might care a lot more about some of these subpopulations and say, well, you know what, when we do that, the elderly get screwed. And so I'm actually not going to do that because I really care about the elderly. And so I'm actually not going to apply these like generically best practices, because they tend to not work well with an elderly population. And so you start getting into like needing to specialize and all that kind of stuff. I don't know if I'm explaining it well.
You absolutely answered my question, so thank you.
Sure. And then I've already kind of mentioned this, but it's sort of, again, the challenge that one gets into when you develop these sort of metrics around quality is that, again, some populations may actually be harmed. So it's not just that it's neutral, but again, some populations may actually get a treatment that is harmful to them. Because again, on average, we're going on average, and on average, this treatment is better for general populations. For certain people, that treatment may actually be suboptimal. And that may be, again, a risk that you're sort of accepting. And just the final thing is, this whole evidence-based medicine, even going back to the definition, relies on this mix of evidence, clinical experience, and the desires and values of the patient. And combining that is really hard. And so there's a lot of art here. It sounds like, oh, you just apply evidence-based medicine, it's a no-brainer or whatever, but the actual application is really hard. And I think that's why you get some of these statistics, right? And I don't know if the ZTA reference is, I want it to be a little sort of, controversial is the right word, but sort of throw out kind of an interesting analogy, because these days we hear everyone talking about, well, we should implement zero trust, right? And the devil's in the details of these implementations, right? So I kind of felt like this might be a little like that, where it's a huge thrust. Everyone thinks it's a good idea in theory. When we look at what's actually happening, there have been a lot of studies on this. Only 14% of practitioners actually use it daily. Now, 80% will reference some kind of guideline at least once a month, but that's not very much if you think about it, right? So there are very few physicians that are just like following this practice constantly. And I one can imagine the various reasons why, but again, it's not that easy, right? To do it well. Requires a lot, puts a lot of pressure, and requires a lot of the practitioner. And so even though I think practitioners might reference the guidelines, and that's clearly a useful thing, once in a while there aren't very many practitioners that are just using it on a regular basis with all the patients they see. It's fairly rare. So I think this is my last slide. Hopefully we can launch into an interesting discussion. Is this a useful model for cyber public health? And if so, is the model at the enterprise level, because that's the equivalent of, the patient, or, we could think about it, again, stepping back, think about trying to apply it more broadly. And are there lessons learned? I guess the other question that came to mind, there's a lot of questions, but one of the other questions came to mind is, how do we get to this concept of best practices? And, when it comes to cyber, and you guys know this, really well, right? There's so many different ways to try to think about best practices in cyber, right? So you've got NIST guidelines, you've got, the Essential 8, you've got the SANS, top 20, you've got, right, a million articles and God knows what. And And, and I think that's where cyber public health is really hopefully going to add some value. And I guess the question is, is the story that we're finding from EBM perhaps useful one way or the other as we think about all that? And I don't know the answer, but that's what I'm hoping we can discuss. So I think these are my references. The slides will be made available so you guys can, take a look at these at your leisure. And with that, I will be quiet and we can dive into some fun discussion. And I'm sorry, I couldn't see the chat, so it looks like there are a bunch of questions there. So
thank you very much. That was awesome. And yes, you've already sparked discussion. And I know Blake has had his hand up, so maybe I'll call on Blake and then let you take over calling on people if we get a slew of hands, or we can just be conversational.
Yeah, so my name is Blake Scott. I'm a senior public health emergency preparedness planner for my community. I'm more of a public health expert than I am a cyber expert, so allow me a little grace and forgiveness in this environment. So I really do think that you're on the right track, especially when you're talking about medicine versus public health. The healthcare and public health sector kind of have this dichotomy. As a public health expert, what we kind of care about is the responders. Let me step back. So let's say a patient with a contagious disease winds up in the hospital. That dangerous contagious disease is concerning to the medical community, but as far as public health is concerned, that patient's already sick. There's not a lot that we in public health side can do for that patient anymore. But what we can do is make sure that that does not spread. And so we are severely concerned with the responders, like the medical responders, those doctors, nurses, and staff, as well as who did they have contact with, where did this come from, and population, like preventing that disease from spreading inside of the population. So there's a really interesting dichotomy that we participate in medical emergencies to some extent, like we're aware of a critical patient that has, like, let's say bubonic plague or something like that. So we would be aware of that patient, but predominantly we're providing guidance and assistance to the medical team when they're responding. So we don't really care about the individual, and that's harsh language, but we are not very particularly interested in the medical event because there are a team of people dealing with that. We care about the responders and the population. And so I think that you're getting at a really important point, that if you're pointing at a computer and saying that computer is sick, as far as public health is concerned, if we're trying to adopt this public health approach, it's too late for that computer as far as we're concerned. That's for the cybersecurity engineers to go fix that thing. That's the medical response of that event. The public health side says, well, let's make sure that the computers responding to that event don't get sick, as well as the general population don't get sick, or find out where that came from, because contact tracing and case investigation is predominantly a public health role, at least in the United States. And so you're getting at a really important point. And so I wanted to say, yes, that is happening, and we see that in public health.
Wow, thank you so much. That's a really interesting point. It's super helpful. I don't know if anyone wants to respond to that. Anybody else is on the call?
So the first thing I want to say is welcome. It is great to have people who have different backgrounds here. And so, I don't want anyone to say, I'm just a public health person or I'm just a cyber person. What we are working our way through is this difficult thing of bringing different communities together. So yeah, I just want to say thank you and welcome. And actually, maybe if I could, if no one else is jumping in, I want to draw on the thread a little bit and ask both Blake and Irv about this dichotomy, because when I think about the work that goes into generating the evidence-based medicine guidelines, there is a population view, right? We pick up on what's happening across lots of patients, and then we go through the process of evaluating quality of evidence and preparing practice guidelines, which then are focused on how I'll pretend I'm a doctor. How do I, as a doctor treating Arastu for a disease, get Arastu the best outcome he can get? But it comes out of having this population level view, I think, maybe not.
If I can, I don't want to control this conversation, but you're getting at a really interesting point. You're talking about definitive care. So in public health, so I've been recently working and developing our disease management plan for our community. And so we have two sides to disease management and disease control. There's definitive actions, things that we know work. And those are usually medical countermeasures. That includes testing, treatment, and vaccination. So those are things that we can medically do to prevent or cure or treat or any like they're definitive actions that we can perform. And then we have like kind of these nebulous ones. And these are what we kind of call non-pharmaceutical interventions. These are those social distancing that you saw during COVID-19, isolation, quarantine, mask wearing. These are non-medical actions. And these are also non-definitive, and they're mostly focused on prevention. Non-pharmaceutical interventions generally do not wind up treating. If you're sick, it's too late. But also what's really interesting in the public health sphere and some of the work that I've been doing to identify peer-reviewed journals is it doesn't follow classical evidence. We do not have evidence-based public health. We kind of do, but it's really ethically questionable whether or not you could do that. And there are really terrible examples in history of us doing exactly that, where we're experimenting with public health interventions on people. So, but like a lot of the articles really, even to this day, say we're not really going to have the classical evidence of a public health intervention working. We can guess, we can use mathematical models to say maybe this will work, but we're also applying non-pharmaceutical interventions in a cultural, sociological, and economic context. And so we're kind of weighing more perspectives, or at least we should be when we're responding to these kinds of things. And so kind of bringing it more to that cyber component, I don't know how that fits very well. I don't know how you can implement non-pharmaceutical interventions in a cyber context right now, because currently it looks like all the computers are basically all in the same room, breathing the same air. And so as soon as one gets infected, the other one gets infected. Whereas in the public, we kind of don't breathe the same air constantly. And so there's like this space, there's this distance that we have, and then public health can kind of intervene with that because we can play with the distance. And so that's an interesting challenge to participate. So that's kind of how I see this. Evidence-based medicine is really important. That treatment is really, really important, especially in a cyber context. You want to fix the computer. It's doing something that you don't want to be doing. But for the public health side, it's like, it's too late for that computer. How can we prevent the other computers from experiencing the same issue?
It's funny, Blake, when you mentioned, separation, of course, I immediately thought about network segmentation and all these other air gapping and all these techniques we try to do on the cyber side. We can talk about how successful or not successful those are, but there is an equivalent. So anyway.
So I got a question from Dan, but Irv, please, can you expand on that idea of network segmentation and like applying that space inside of a public health context or evidence-based medicine in this context?
So I can. There are people on the call who know this stuff way better than I do. So, and I'm happy to keep talking, but if anyone, Dan or anyone else who, Adam, you guys who've had your hands on this, I'd love to open it up to have others jump in. If not, I'm happy to keep talking, but.
Why don't you keep going? Because I'm sort of, my head is swirling a little bit about the segmentation and the ZTA and where it is zero trust architecture, where it fits. And I don't know that I have anything intelligent to say just yet, but I'm working on it.
Oh, okay. Yeah, well, I guess, Blake, just at a high level, I mean, there are ways to architect networks to sort of create, I don't know what you want to call them, neighborhoods, communities, clusters, in such a way that, you know, if one is infected, you can sort of isolate it. So you can sort of have networks where you can actually, you know, manage that dynamically. And then there's another technique where you have things that are just separated all the time. So the term is air gapping. So you have networks. So in theory, there is no direct connectivity between one network and another network. So if something bad happens, it actually hopefully can't touch the other network. But unfortunately, there are ways around that, which we have lots of examples of. But
yeah, so you're getting that I think is a really interesting, that isolation and quarantine idea. And so we're developing our isolation and quarantine guidance and frameworks. And so kind of to merge in that isolation and quarantine, which is more of a public health intervention than it is a medical intervention. Isolation, kind of more. Let's start with terms, because even the news gets this wrong. Isolation separates sick people who are with a contagious disease from people who are not sick. Quarantine separates and restricts the movement of people who are exposed to a contagious disease to see if they become sick. Something that's really interesting about that, I am proposing in my own guidance is for voluntary. So I've developed 4 principles based off of academic research, that isolation and quarantine should follow these 4 principles. And they're mostly, it's easy to isolate a computer. You can just throw it in a room and say, I don't want to talk to you. There's not a lot of ethical questions about whether or not that's a person. Like, we do not like, oh yeah, I tell the computer to die and we just kill it. But we don't like doing that. So our 4 principles are informed, voluntary, supported, and short quarantine. And that one's specialized for quarantine. And then we also saw, and going back to your discussion, Dan, about the coercion effect. Public health has a tragic relationship with the ethical principles of isolation. We have put people away. Typhoid Mary is a great example. For decades, that poor woman was placed on an island in the middle of nowhere. And what's really interesting about that is isolation and quarantine is really just a focus on the known. You know this person has an illness, and you completely ignore everyone else. And so back in the 1980s, we were seeing studies, especially with the HIV crisis, where, hey, you're only focusing on people that you know have this illness, and genuinely, historic isolation and quarantine were highly discriminatory and enacted against the lowest socioeconomic classes and the least articulate of the public. You only enforce these because enforcement of these interventions, specifically isolation and quarantine, can draw significant resources away from the overall goal of public health. We only use, and I am only going to advocate for isolation and quarantine, forced isolation and quarantine, in the containment stage of a disease outbreak. It is ludicrous to think that we would waste resources on trying to find every single case in the COVID-19 example. Why waste the resources? We can focus way more resources on education, informing people, hey, you should voluntarily stay home if you can, please. Because that's also a focus on the people that you don't know, that you can't confirm are sick. Because in public health, if you focus so heavily on the people that you know are sick, there's still some guy or some person out there that has a disease that you don't even know. It fits in that unknown, and then you're just like, oh, okay, we're going to spend a ton of money and resources on this one person that we know has the disease, and we're going to ignore the people that have the disease, but we don't know about it.
Sorry, there's such a great analogy there to Brian. Brian Lewis, do you want to jump in on this one? I think you and I are on the same page here.
Yeah, I don't have a great mic, but I will jump in. Yeah, we are totally on the same page, and it's a fascinating concept to think of the way we try to respond to, especially rapidly propagating cybersecurity incidents. And we do end up treating them a lot the same way as these public health emergencies. And so I'm on the same page as you, but I'm also in the same situation as Adam, where I'm like, wow, I've got so many fascinating thoughts swirling around, especially how does this drive home the message about why zero trust is important? How does this affect our general, proper response when we notice there's a cybersecurity incident? Because frankly, it's not just public health who has a history of getting things wrong. We in cybersecurity have gotten things very wrong a lot of times as well. So even if I don't have anything great to contribute, I absolutely want to underscore the value of this discussion and how mind-opening it is to compare the analogies in two directions between cybersecurity and public health, because that's what I've noticed is we're going both ways. We're comparing cybersecurity, public health. We're also comparing public health to cybersecurity, and it's really great. Thanks for giving me a chance to weigh in. Sorry I didn't have more, but those are my thoughts.
Actually, you triggered something, if I may. Irv, could you bring up your slide 6?
Sure.
And I think that was the one about the levels of evidence. And what I'm thinking about is how could we think about levels of evidence
Is this the one you want?
for zero trust? What we have today, maybe, I think we can reasonably say we get to level 3 for zero trust case studies, or maybe cohorts that are not well designed. Do we get up to level 2 in our evidence for zero trust? Since nobody's answering that, let me ask a different question. If we have, say, 100 firms or 50 CFO agencies in the US government that are deploying zero trust, and they do so in somewhat different ways, and we can look at their outcomes, right, in the US government level, because they have to report incidents to US CERT, can we construct, it's not, I'm looking at the words in your levels here. Can we treat that as a cohort study? For example, maybe cohort 1, and I'm just picking firms at random here, maybe cohort 1 would be Palo Alto Networks deployment of zero trust, and cohort 2 would be a Microsoft deployment of zero trust, and we can just throw people into the cohorts and learn about what's happening differently between the cohorts.
You're essentially talking about a naturalistic study, like when an intervention is applied to a group of the population, but not applied to the other. And so that does, yeah, I would agree with that's a possible approach.
And do you know what level those are treated at for EBM? The phrase naturalistic study isn't one I'd heard before.
I'm parsing words. You're asking for specifics, and I'm aware of the medical side. I'm more of a public health expert.
Okay, fair enough. I didn't mean to put you on the spot. I'm just exploring the ideas.
I'm certainly not an expert. My initial sort of gut reaction is what you're describing would either be level 2B or level 3, depending on whether it was, I'm doing air quotes, well designed. But that's what it seems to be, right? Because it's not, I think to jump to the next level, you'd have to do a controlled study, which essentially means you're comparing groups that get the intervention and groups that don't. I think, anyway. Not sure that's right. I would probably have a research methods person, talk to a research methods person to get a more stronger answer, but.
Okay.
One interesting thing that I also noticed, and just to bring up more fascinating analogies, I really appreciated, Blake, that you went through and clarified some terminology that a lot of people get wrong. And Adam, you said deploy zero trust, and I'm thinking, well, do you deploy zero trust or do you implement zero trust? Is zero trust a product or is it a policy and a procedure? So I think that sometimes it's really useful, just like Blake did, to say, wow, we have to recognize that some of our vocabulary may also hint at different understandings, perspectives, and philosophies on things. So that was something that I picked up on there, was deploy zero trust is a very common statement, but then there's also the question of, well, do you deploy or do you implement apply? Anyway, just another great thing that's come from it.
I am the world's worst person on definitions. I tend very strongly to use English terms, sometimes a little too loosely. And one of the things that I've been learning, including the talk that Dan gave at the start of this series, is how precisely defined words like incidence and prevalence are. We just heard about the relationship between isolation and quarantine, which I have absolutely been getting wrong.
As far as we're concerned, we don't care. As long as you stay home. That's the important. We don't care. Honestly, it doesn't matter that much. It's parsing specifics, and it's just like, it's not important. The intervention was more important in the first place.
So what's important? So sorry, go ahead.
I wanted to kind of drive on, Irv, you were talking about a really interesting point about a tilt towards the mean, or a tilt towards mass. So that average base, when you're applying medical studies and tilting towards the mean, you brought up some really important points about what we think about in the public health side, is that underserved populations, generally oppressed populations, Black, Native American, those kinds of populations are generally underserved by the medical community for a lot of different reasons. We're trying to address that in public health. For a particular example, the Native American, so we're just going to do statistical studies, and I'm going to give you anecdotal evidence. My community, Coconino County, is a county that's small in population. So we have 145,000 people in the entire county. They're spread over 18,633 square miles. That's larger than 8 states. So we have an enormous territory to cover. And so when the federal agents provide and say, hey, about 90% of the population live within 5 miles of a pharmacy, that's true, but that's on average, right? In my county, if you evaluated that, only about 1/3 of my population actually live within 5 miles of a pharmacy. And so it's really a matter of where you measure. And so that tilt towards the mean, like, oh, they're able to say, hey, the general population lives within 5 miles of the population. Yeah, when your unit of measure is a country, when your units of measure get smaller, then the nuances and the uniqueness of the environment presents itself in a really unique way. And so for more context on this idea is my population by the Census Bureau says it's about 90% white. So that's non-Hispanic, white, American kind of stylistic. And then we had a smaller portion of our population is Black, Native American, and so on. We have a supremely large territories of sovereign nations, these Native American nations. Navajo Nation was tragically devastated by COVID-19. Over 80% of our death, so outcome of died from COVID-19 was Native American. So that outcome of 80% of our death being Native American, but 90% of our population actually being white suggests that we're having uneven outcomes. And really that tilt towards the mass of the population, a focus on, oh, let's take care of the most people, still can result in a negative outcome for your most vulnerable. So we're kind of trying to tilt, we're trying to say, well, the mass is going to be fine. Like they'll be fine, they'll figure it out if we can focus on the highest risk populations. This is called access and functional needs in emergency management. If we make sure that the most vulnerable are taken care of, then we can support the majority of people. A particular example is using ramps. Ramps are easier than stairs because even people in wheelchairs can go up them. And walking people can go up ramps. But if you only have stairs, then only walking people can go into your building. So that's kind of breaking it down. And yeah, that tilt towards the mean is a really important consideration in public health.
Blake, I'm going to back Dan Gear. I'm going to back you up just a little bit. Let's take the elimination of smallpox or polio or something like that. At the outset, it obviously is good policy to anybody you can find vaccinate, anybody who's willing. But to get to the end, you know, where's those last 13 cases of guinea worm, or where's the last 300 cases of polio, or you get the idea. At that point, you have to switch in some way or other from, well, I hope they walk in, or I hope they see our advertisements, to we're going to look for them. I doubt you've had experiences in that, but if you have a viewpoint on what the switching rule is for purely advertising / voluntary to the opposite. Any comment on that?
Yeah, you're kind of talking about disease management strategies now. We have 3 inside of public health. We have a containment-based approach, a mitigation approach, and a suppression approach. When you get to small-scale disease, like let's say you have 13 cases inside of a community, that's controllable. We can use tighter restrictions like isolation and quarantine.
Sure, like I assume you have reportable diseases in your state.
Yes.
Mandatory reportable diseases, for example.
Yes. And so those become a little controllable. If you can catch them early, then you can use a containment strategy. If they get out of, if they break containment, then you have to start falling into mitigation or suppression-based strategies. There is ethical questions. As a public health professional, everyone should get vaccinated. Go get your flu shot, everyone. Like, everyone should get vaccinated. And there's a lot of reasons for that. Because there's also that whole protection of people who can't be vaccinated. There's a bit of that. Chasing down, you're kind of talking about like eradication of disease, and I'm not super specialized in that, Dan. I apologize, but I hope I'm at least getting at.
Yeah, well, I actually have a little background in this, but on the cybersecurity side, because rate of spread can be more or less instantaneous, you know, the eradication aspect, I think, carries more weight, carries more policy weight. You know, we've got to get, I'll name one that may not be recognizable to you. We've got to get code red off the network. It's ridiculous that it's still out there after 10 years. That kind of we have to eradicate, and it's coming up in an entirely different setting that we don't have time to pursue, but it has to do with national policy mandating resilience standards. You know, you will be resilient to the following, whether you like it or not, Mr. Pipeline, Mr. Electric Network, Mr. Water Treatment Plant. And resilience often means you must be vaccinated in a sense. You must be running the latest release of software. You must have a way to do updates and so forth. What's ill-formed as a question is whether or not there is a place for coercion based on criticality. This is a critical infrastructure. You don't get to choose whether you will run the latest protection software. You will run the latest protection software, and so forth. And I'm a little torn because, again, I have some background on the public health side. I'm a biostatistician, for what it's worth, but I also have a background on the computer security side. And in fact, this question of what is the appropriate regulation to ensure that critical infrastructures have resilience to cybersecurity insults is a hard problem and far from solved. Hence my interest in what are the stopping rules for voluntarism and the conversion rules for coercion. But that may be out of scope for today's conversation.
So I know we're at time, but Audrey, you've been really patient. Adam, is it okay to squeeze in a little more?
I was going to call on Audrey because she had reservations.
Okay.
Yeah, that's all right. I'm hoping not to be too long. Two things I was thinking, and it was first by hearing Blake and then seeing the comment of you of it's protection. You know, you can have you aim for the average, and then you've got the top, bottom, and the bottom and the top. I think in health we reach a stage where we have done the average, but we are not good yet at doing the non-average. And I was wondering if the analogy with cybersecurity stuff is that we haven't yet managed to do the average, and it was also linked, I think, with you, Adam, on the small business, the SMEs. I mean, roughly that 98% of businesses, which means it's the average. Let's put it this way. And we haven't sorted that out. I think a lot of SMEs just don't have good cybersecurity practices. That's at least a lawyer here. So I'm not a cybersecurity practitioner. So I think, is it that all these questions also is, if we want to build better cybersecurity, where is the average? And where are the bottom and the top? And then building for this, I think critical infrastructure for me, they are by definition essential. You can't regulate them like the SMEs. And for the last comment, I'm a lawyer, so yes, you do need regulation, and you can't count on voluntary basis. At one point, it always moves to the law. The history of regulation is always like this. You move from voluntary, you set up an institution that has no sanctions, power to sanction, and then at one point it doesn't work and you move to power to sanction. And that's something that has been like this for the past 200 years. So we are going to have to see more regulation. Stopping here.
So I'm just wondering, I would love for there to be, if I'm just to throw out a topic, but I'd love for there to be a follow-up discussion where we actually talk about these issues of a regulation, which I'm guessing we're going to come up over and over again, and also maybe this issue around small, medium enterprise and also civil society. You know, I'm supporting the Cybersecurity Infrastructure Security Agency in the United States right now, and it's a huge topic on their minds. Like, they are very, very aware of this challenge. It's very hard to solve. So if we can think about where cyber public health can sort of apply to that, I think that would be a fantastic topic. But anyway, just throwing that out. So,
can you help us find speakers, Irv? We have a forum. Help us find folks to come.
Sure. Actually, I've got a great speaker on that talk. I've got a couple of people on that issue specifically. So no problem.
And I thank you so much, Audrey. I think you're really getting at it was a really interesting state for and I posted this in the chat. So like the average human state take that with a huge gigantic grain of salt. For an average human state is naturally well, like the immune system usually works. And so what's really kind of interesting to apply that to the cybersecurity space is what I'm seeing is like the average computer is naturally vulnerable. It seems that they don't have natural immunity. They can't generate a homeostasis that moves them to a healthy state. They don't naturally get well. They have to be intervened on. And that's kind of an interesting state. And then Irv, on your element on regulation, we have the food code. In local public health, we have people that drive to small businesses called restaurants and they inspect them every month. So that regulation is determined to be fine. We had the Pure Food and Drug Act that started the FDA, and then we had food inspections and food codes. Like, restaurants have to follow a certain standard because they got people sick. I think what we're not there yet with regards to cybersecurity is I don't think people say, oh, I got sick from this cyber virus. Like, my personal protected information got released by Microsoft because of and something. We don't have the consequence isn't naturally felt by the public yet. And they're not doing that risk evaluation. We know when we're food poisoned very quickly. It is not a pleasant experience, and we decided that was not okay. Pure food and drugs were a really important part of our society, and it was really obvious when the consequences occurred. It's a little nebulous what the consequence is to the general public with regards to cybersecurity. I think there will eventually be a moment in which we experience that, like all four cars, because they all have computers inside of them, will suddenly shut down because a virus wipes their boot drive or something weird. So when we get to that cyber Black Death event where everyone has experienced a cyber event at the same time that they can point to and say, yeah, my mother got impacted by this event, I think maybe that cybersecurity will get more, or shift it to the local, where we start to have localized inspections, which, yeah, that's a regulation. We can kind of talk about that, but there's some really interesting stuff that local governments do that federal governments don't do. And that's a whole other conversation that I love telling my new employees, hey, welcome to the government. This is something completely different than you expected. And local governments usually do a lot more work than you thought.
So Blake, that was you volunteering to come back and speak at some point in the future.
I would love to speak on disease management control, especially incident response. I think incident response in cybersecurity is kind of missing the ball. Emergency management as a field has kind of been developing in a particular direction, and they have these standardized response methods. Cybersecurity kind of have to respond a little faster, but cybersecurity seems to be like taking the ball and walking away from the table. Whereas we've responded to all hazards. Literally every other disaster in this country is managed through the emergency management standards. Not saying they're good, I'm just saying it's standard. And cybersecurity seems to be going, oh no, we want to go do this other incident response metrics and develop this other way of responding to an emergency. And I'm going, we have a standard. Why are you playing over there?
Possibly because we have too few meetings like this where we get folks cross-pollinating and educating one another. So I think we've got a couple of, and I'm cognizant of the time, I think we've got a couple of future topics of emergency management. I did not write down, I'm sorry, Irv, but I'm going to contact you to ask about speakers. And so I wanted to say thank you to everyone who joined in to hear from Irv. Thank you so much, Irv, for a fantastic, provocative presentation that led to some great conversation. And I do want to mention that we are looking at getting together in New York on January 9th. You should be hearing from us shortly about that event. And as I mentioned at the start, this, just because of coincidental when our meetings fall on the fourth Thursday, we're going to miss the next two. So, you know, everyone have a great holiday season. Stay healthy, get your flu shots, get your updated boosters. I can say this, we're in a public health meeting. And we'll look forward to seeing you all next year.
Thank you all.
Everybody,
In January.
take care. Bye.